Well, good afternoon and good morning as time zonally appropriate. I'm David Glazer. I'm here with my colleagues, Marguerite Amon, Catherine London, and Pari Magera, and we are going to go through the 2018 regulatory update. Some years, this is really exciting. This year, okay. So our standard quick announcements. So first, the next webinar will be January 17th, and Briar Andreessen and Steve Helland are going to talk about electronic health records contracts, and they have learned a ton of stuff. It will be really interesting. I learned a lot from this one. And then actually we know the next webinar, which is on Valentine's Day, and in an appropriate twist, Katie Hilton and I are going to talk about Medicare appeals, which just feels very Valentine's oriented, I think. So those are the next two webinars. Past webinars are available on our website. If you just Google Fredrikson Health Webinars, you can see, I believe we've got 3 years of them online now. They're free, a whole bunch of topics covered. You can go through that. Two final points, the sound we've discussed. If the sound goes south, as it sometimes does, you can look. Robert has sent the number out, dial in. That's always an option. We pay for it, so if you can listen through your speakers, that's freer for us. But if the sound goes south, do that. And then finally, please fill out the evaluations and a weird quirk on evaluations. Usually when people give you an evaluation, you can assume that it is not really anonymous. You know, when like Delta sends you the little thing, they know who you are most of the time. This is truly anonymous. We do not know who you are. So if you say something in there where you want us to follow up, we will not know who you are. So please include your name if you want us to do anything about the comment. But we really did read them, and in fact, we added a new question this time because we often go over by a little. And so one of our questions on this survey this time is, do you mind? You know, we view this as we view going over as it's free. If there's a little extra information, it's good. But I know some people are troubled by that, and so now we're curious as to how many of you are. So please fill out the evaluations. Now, that warm up, let's dive in. I'm going to talk real quickly about a couple of case highlights. Then turn it over to Margie, who's going to talk about the physician fee schedule. We'll then go to the Outpatient Prospective Payment System, and then the Inpatient Prospective Payment System. And then I will bring it home with a very fast summary of some of the things in the OIG Work Plan. The OIG changed their approach. They don't do a work plan anymore. They now do like continuous updates, and we'll rattle at a high rate of speed through some of those. So here's an I had an interesting little, I'm almost going to call it a dust-up with the Department of Justice. So I was lucky enough to be at the Healthcare Compliance Association meeting at the end of October, their fraud enforcement conference. And I was listening to a talk by Michael Cranston, and he said, despite the significant role that TTAM claims continue to play in the department's False Claims Act efforts, it remains the case that the department intervenes in only about 1 out of 5 cases that are filed. The impact of those non-intervened matters can be significant, but not only in terms of them initially, but also in terms of monitoring and ensuring litigation if the relator elects to proceed. But this is where things get interesting. While TTAM cases will always remain a significant staple of the government's false claims efforts, we're mindful of the need to maximize the use of the government's limited resources. We will therefore continue to look critically at TTAM cases to determine whether these matters should be dismissed. While the TTAM provisions were designed to provide relators with a vehicle to proceed without the government's involvement, clearly meritless cases can serve only to increase the cost for the government and healthcare providers alike. So I heard that and went, wow, this is big news. Because when I was a baby lawyer back in like 1996, my colleague John Lundquist and I were working on a case. It was kind of an interesting case. A Part B and Part A medical organizations had both billed for the same services. And you would think, they double billed. They must lose, right? Well, if you followed the instructions for Part A through to the end, and you followed the instructions for Part B through to the end, it made sense to pay them both, okay? It was logical. We convinced the government of this, and they intervened to dismiss a lawsuit, and that was great. We were told as that was happening, enjoy it because it's the last time it will ever happen. As a matter of policy, the Department of Justice will not intervene to dismiss lawsuits. They'll let courts dismiss them, but they won't move to dismiss them. So I heard this, we will dismiss things, and my ears perked up, and I wrote an article about it. Then I got a call from the Department of Justice's press office saying that I misunderstood Mr. Granston and that there had been no change in policy. This is a long-standing policy. And I said, really? That's cool. Can you give me some examples of cases where this has happened? Because I think this is big news. And the press officer said, oh, whether there are examples or not is not material. And I said, I beg to differ. I think it is material. And so we went around and around on that for a while. And then I did, in fact, get 8 cases. Now, a couple of the cases are, I guess you could say, unusual. One was a case that claimed that the government, that Barack Obama's lack of citizenship meant all of his actions were false claims. Another involved waterboarding. So they weren't necessarily what you or I would think of as Healthcare False Claims Act cases. But there were 2 cases where the government had moved to dismiss. So it is possible that this isn't breaking news and that it was a change in policy that happened some time ago. But I still think this is significant, and we mention it. And here's why I think the government thought this was a big enough deal to call me. About 2 weeks after this happened, the government moved to dismiss a case. And it's a case worth talking about. It got a lot of press, not for, I think, the right reason. So the case involves HCR ManorCare and skilled nursing facilities, where a relator brought a claim that was filed in 2009, although if you read most of the articles, they talk about it being filed in 2015, because that's when the government intervened. First interesting point, 6 years is not really a long time for that. That's kind of, in our experience, it is not unusual to have a case fester for 6 years before a intervene or dismiss or decline decision is made. It was looking at the medical necessity of therapy for everyone who's been involved with an advanced med review. Advanced med did this review, and they got in a world of trouble. The expert who was going to testify was asked if she had any notes, and Rebecca Clearwater is her name. She said no. Well, it turns out she had a 133-page notebook and then a 5,000-page Excel spreadsheet with comments on it that she apparently didn't consider to be notes. Then they also asked her if she'd asked her supervisees to produce their notes, and she said no. And then government lawyers asked the supervisees if anyone had asked them, and they said no. So the court concludes she's a liar and throws out her testimony. That got a lot of play. That obscured the interesting question, which is the court also refused to allow her to testify because they decided she was not qualified because her qualifications would only allow her to testify as to obvious billing mistakes. They said she's not a medical doctor, not an occupational therapist, not a speech-language pathologist, and so she can't opine on the therapy. And that is the big lesson in this case. When you're in a medical necessity fight, challenge the expert. And that's the big lesson out of this case, and I think an underreported lesson out of this case. So, with that wind up, we now move on to the thrilling physician fee schedule. So Margie, I know, Margie does a lot of transactional work, and it's year-end, so she's super busy closing a bunch of deals, and I know at least one professional services agreement, but she has studied the physician fee schedule. Take it away.
Thanks, David. So yeah, I'm going to touch on just a few of the highlights from this year's final rule for the physician fee schedule. Obviously, I cannot cover it all or all of the nuances in there, but this will at least give you some insight into what we thought were some interesting aspects. So it was just recently published in the Federal Register on November 15th. And overall, CMS finalized the majority of its proposals that it had laid out in the proposed rule, which were kind of a slew of changes to mostly existing programs. As always, a significant portion of the rule covered some of CMS's number crunching. They finalized the 2018 conversion factor at about 35.99, which is a slight increase over the 2017 conversion factor. So this takes into account the 0.5% increase as mandated under MACRA, but counteracting that increase and fairly consistent with what we've seen in previous years is the cut that's imposed under the Misvalued Code initiative that was part of the Achieving a Better Life Experience Act of 2014, better known as the APL Act. So before moving into kind of the guts, I wanted to ever so briefly touch on one of CMS's recently launched initiatives, one they're calling the Patients Over Paperwork Act, which has, or Patients Over Paperwork Initiative, which has a nice ring to it. I put a quote on the slide, which comes directly from CMS, but essentially their goal is to evaluate and streamline regulations with the goal of reducing unnecessary burden, increase efficiencies, and improve the beneficiary experience. So this is really to kind of counteract some of the growing amount of paperwork that CMS has seen as taking doctors away from what matters most, which is the patients. That was a quote from CMS Administrator Seema Verma. And the initiative is broader than the physician fee schedule, but the physician fee schedule was kind of the first we've seen of CMS explaining exactly how it intends this initiative to play out in practice. And so two of the things that I put up here are things that CMS has says that it attributes to this initiative within the physician fee schedule. So that includes reducing reporting requirements. And we see that at least in one example in the PQRS, where they've kind of retroactively decided to reduce some of the reporting metrics, and then removing downward payment adjustments based on the performance for practices that meet minimum quality reporting requirements. And one area where they've done that is within the value modifier, kind of reducing some of the downward adjustments there. But we'll be eager to hear what people think and whether this makes a significant impact in their practice. All right, so on to some of the more core content. I'm going to start off with the off-campus provider-based departments new payment policy. So just as context, earlier this year, CMS began implementing what was a fairly controversial site-neutral payment provision from Section 603 of the 2015 Bipartisan Budget Act. As you may recall, this was designed to equate payments for the same services whether they were provided at an outpatient provider-based department or a freestanding clinic. And what they did was for non-accepted new off-campus provider-based departments, they came up with a site-specific physician fee schedule rate, which they're referring to as the PFS relativity adjuster. And in 2017, that was equal to 50% of the OPPS rate for those services. And in the proposed rule, they dropped this down to 25%. But after significant pushback from stakeholders in the comments, they set this at 40% for 2018. And CMS acknowledged that there's not a lot of data for them to base this new PFS relativity adjuster on. And so they indicated that for 2019, they will finally have a full year of data from 2017 to make kind of a better, do better calculations to come up with the 2019 rate. Ooh. Okay, CMS finalized some new components of the permanent expansion of the Medicare Diabetes Prevention Program. The expansion is set to begin April 1 of 2018. And to jog your memory, the MDPP is intended to reduce the progression of type 2 diabetes by targeting the pre-diabetic population with prevention services. So in the 2018 final rule, they finalized policies to pay providers using a performance-based payment structure. So they'll tie payment to performance goals based on beneficiary attendance and or weight loss. And they also finalized a policy that will allow suppliers to provide in-kind patient engagement incentives to kind of promote the programs that they have in place. All right, under the Protecting Access to Medicare Act, there was a new regulation that required professionals furnishing advanced diagnostic imaging services to report on their Medicare claim information about the appropriate use criteria, or the AUCs, reviewed by the ordering professionals. Each year, for the past few years, CMS has put out kind of new incremental information about how this program is going to come into fruition. The statute requires the program to begin January 1 of 2017, but CMS has pushed this back, and in the proposed rule, they said they were going to start it in January of 2019, and then in the final rule, it was further delayed until January 1 of 2020. So starting in 2020, physicians and ordering professionals will start using these appropriate use criteria in order to report out their imaging services. And before that, the agency is implementing a kind of voluntary reporting period that will begin in 2018. And I think that the big benefit there is that providers who choose to start reporting in that voluntary period will be able to report this qualified clinical decision support as an improvement activity under MIPS. They also had some proposals to try to align exceptions under the AUC program with MIPS. And while they didn't finalize that, they have indicated an intention, at least, to continue to try to align the different quality improvement programs. All right, not a ton to report on PQRS because, as I'm sure you're all aware by now, 2018 is the final year for payment adjustments under the PQRS program. The last reporting period was 2016, and the last data submission was Q1 2017. My apologies, it's not 2018 as it says on the slide. So the reporting and submission is all in the past. That said, CMS did decide to retroactively lower the number of required measures from 9 to 6, and that was in an effort to more closely align with the MIPS program. So the benefit is for clinicians that didn't meet 9 but did report out on 6, they won't be subject to that non-reporting penalty. That is a 2% negative adjustment in 2018. CMS also finalized a number of updates to the Medicare Shared Savings Program within the final rule. Among the most notable is a change regarding the ACO beneficiary assignment methodology that they're using. So under the ACA, beneficiaries are assigned to a shared savings program ACO based on their utilization of primary care services for physicians participating in an ACO. And this final rule allows beneficiaries to be assigned based on their utilization of services furnished by RHCs and FQHCs. So that will go into effect starting in 2018. CMS also relaxed some application submission requirements, specifically for the exception to the SNF 3-day rule, or to get a waiver for the SNF 3-day rule. And they also made some updates to the definition of primary care services, again, going back to how they assign beneficiaries to a particular ACO. Just a few other changes that I wanted to mention briefly. I kind of already touched on the misvalued code initiative. Another one that CMS finalized is a proposal that beginning January 1 of 2018, they will have a new modifier for reporting imaging services that are specifically for x-rays taken using computed radiography technology. So the modifier will be tied to a 7% reduction in the technical component payments for those imaging services, and that will be in effect for 2018 to 2022, and then from there on after it'll increase and be a 10% negative reduction. They also finalized certain HCPCS modifiers to be used to identify the patient relationship categories. And let's see, Finally, before I'm going to turn it over to Catherine to cover some telehealth updates, there were a few other areas that CMS did not make changes, but indicated that they have an intention to do further rulemaking after some additional comments from stakeholders. The first is for the clinical laboratory fee schedule. As many of you know, there is a new schedule based on data collected from clinical laboratories, and they've been getting significant pushback in the data submission process. So in the proposed rule, they sought feedback, and then all they've really done in the final rule is thank the public for the feedback, but also indicate that they have some intention to make some further rules or issue some sub-regulatory guidance on that. And they also sought feedback on what they see as something that needs some broader, more fundamental changes, which is the E&M's documentation guidelines. So they've solicited comments and intend to do more with that in the future. I will pass this over to Catherine to cover some of the telehealth updates under the physician fee schedule.
And before Catherine dives in, I'm gonna note maybe three quick things. So first, Catherine has been heavily ensconced in the medical device world lately, working on kind of the regulatory stuff and spending a lot of time at one of our clients. And I mention that just to note, we've got a bunch of brain power here. Three of the people around me are part of it, and we're happy to either come out and hang out at clients and also do research. I know if you are an in-house lawyer, it is often hard to find the time to do research, and folks here can do that for you. And I know there are some law firms that are very hierarchical about who you call. Fredrikson is not one of those. You could and should directly call. You know, if you're impressed with or have a question about something Margie just said, yeah, call her. And so with that as a wind-up, I know that Catherine took some time away from medical device stuff to dive into telehealth and the outpatient prospective payment rule.
I sure did. So I am going to finish up the fee schedule before moving on to some other positively scintillating regulatory updates from the OPPS. But first, I should mention that every year in the physician fee schedule final rule, CMS adds codes to the list of services that are covered if they're furnished by telehealth, and also requests stakeholder input about new codes that should be added to this list. And generally, these requests fall into two categories. Category 1 services are those that are similar to services currently covered if they're furnished by telehealth. And then Category 2 are not similar to services that are currently on the list and therefore require evidence demonstrating that there's some sort of clinical benefit to the patient if they will be provided by telehealth. So for 2018, CMS is adding 7 new codes to this list, and I've included them on the slide here. 3 of them are added on a Category 1 basis, and 4 are considered add-on codes that describe additional elements for services that are currently covered by telehealth. Notably, CMS has also finalized a separate payment for a code describing certain remote patient monitoring services. And this will allow practitioners to bill for time that's spent collecting and interpreting health data that's generated remotely by the patient and then digitally stored and transmitted to the practitioner. So in order to bill for this code, practitioners have to spend at least 30 minutes on these activities. They have to initiate the service during a face-to-face visit and also obtain advance consent from the patient, which is documented in the medical record. CMS has also decided to eliminate the reporting of the telehealth modifier, the GT modifier, from professional claims. And historically, CMS had required distance site practitioners to report this modifier on all claims designating that the services were provided by telehealth. But last year, CMS implemented the use of a new place of service code for telehealth services, which essentially rendered the use of this modifier redundant. So for 2018, CMS is eliminating the need to use this modifier on telehealth claims. And I should finally mention that CMS also declined to add a number of other services to the telehealth list, such as certain PT, OT, speech therapy, and other online E&M services, basically explaining, as they do almost every year, that they're restricted under the current statutory framework, which is why the expansion of telehealth coverage services continues to be very, very slow. Moving on, I'm going to touch on a few highlights to changes that were included in the OPPS final rule, which was published on November 1st. First, with respect to OPPS payments, the final rule provides a 1.35% increase for 2018, and this is based on a 2.7% market basket increase, which is partly offset by productivity reduction and also some adjustments that were required by the Affordable Care Act. And touching on a few other highlights here, CMS has extended a two-year moratorium on the enforcement of the direct supervision requirement for therapeutic services that are provided to outpatients in critical access hospitals and certain small rural hospitals. I always struggle with that word every year in this webinar. Small rural hospitals having 100 or fewer beds.
The rural juror from 30 Rock.
The direct supervision requirement has been applicable to these providers for many years, but historically not enforced due to stakeholder concerns about the difficulty in staff recruiting, particularly with respect to specialty services for these providers. And so in 2009, CMS imposed a moratorium on the enforcement of this requirement and has decided to extend this non-enforcement instruction for 2018 and 2019. And then lastly on the slide, I want to mention that every year CMS reviews the Medicare inpatient only list and decides whether there are any procedures that should be removed from that list and thereby becoming eligible for payment under the OPPS. For 2018, CMS has decided to remove 5 codes from the list, including total knee arthroplasty, which I wanted to mention here because there was also a lot of commentary in the final rule about whether total and partial hip arthroplasty or hip replacement should also be removed from the inpatient only list in future years, and basically signaled a move in that direction in the future. But some commenters had raised some concerns about the impact this change could have on the CJR and BPCI initiatives, noting that shifting these knee replacement procedures to the outpatient setting could potentially skew some of the statistics and affect providers, since performance under those programs is based on the historical cost of the procedure. Specifically, commenters were noting that the beneficiaries who are likely to receive the procedure on an inpatient basis would be more high risk and more likely to require additional post-acute care, which could increase the average payment of the inpatient episodes and affect the hospital's ability to basically fall below the target price and generate savings. And in response to this, CMS basically just said it doesn't expect a huge shift in the procedures to the outpatient setting from January 1st of 2018, when this new policy goes into effect, until the current end dates of the performance periods under those initiatives, and basically brushed off a number of those concerns. So lastly here, CMS is also precluding RACs from conducting site of service reviews on outpatient knee replacements for a period of 2 years, starting on January 1st. Perhaps the most controversial change in the OPPS final rule is the adjustment to the amount that Medicare will pay hospitals for drugs that are purchased through the 340B drug discount program. And this is intended to address increasing drug prices and a very large growth in provider participation in this program in recent years. And so under the new policy for 2018, CMS is reducing the OPPS payment for separately payable non-pass-through drugs and biologicals other than vaccines, which are purchased through the program, from the average sales price plus 6% to ASP minus 22.5%. There are some providers that are excluded from this change, and those include rural community hospitals, children's hospitals, and certain cancer hospitals. But this is expected to result in a $1.6 billion decrease in drug payments for these providers. And drugs that are not purchased through the 340B program will continue to be paid at the ASP plus 6%. This is obviously a huge change, and CMS is offsetting this projected decrease in payments by redistributing an equal amount to hospitals for other non-drug related items and services across the OPPS. So a few things to note about this. In arriving at this new policy, CMS relied on a few different studies and reports, one from the MedPAC, which found that during a 5-year period reviewed Medicare spending grew significantly faster among hospitals that participated in the 340B program than those that did not. There was also a GAO report that found that beneficiary Part B drug spending on average was significantly higher at 340B hospitals, and that beneficiaries at these hospitals were prescribed more drugs or more expensive drugs than beneficiaries at non-340B hospitals. And so CMS really kind of capitalized on those studies, which both recommended using an alternative payment method for a 340B program moving forward. But CMS received a ton of comments to the proposed rule, contending that they lacked authority to implement such a huge payment cut, which would essentially eviscerate a lot of the 340B savings for many hospitals. And commenters also noted that, or also argued that CMS couldn't impose this type of a cut without providing a sufficient and replicable methodology to support it. So in response, there were pages and pages of CMS commentary in the final rule, claiming that CMS has broad authority to adjust the hospital payments for outpatient drugs based on data that's received by the Secretary, and that there is sufficient authority for the Secretary to make this change. So what's happening now is that several hospital associations and providers have all filed lawsuits seeking to block this new policy, and I think we're going to see more happening with that in the upcoming months, so everyone should stay tuned there. I will move over to David here, and he is going to introduce the next section of the webinar.
So before I hand this to Pari, Pari spent her morning this morning in a provider review reimbursement board hearing, which I believe is the third one she's been involved with this summer, I think, which is kind of amazing. Pari does a boatload of litigation on a variety of topics, and mostly spends her time coming up with creative ways to get people out of trouble, including the arguments in that one. But here, she's going to walk us through the inpatient prospective payment rule, and try to keep, I don't know, this is, try to find some kernels of interesting stuff.
Right. The Inpatient Prospective Payment System final rule is published this August in the Federal Register. I'm sure that you're all waiting with bated breath to hear about this rule, but I just break it to you now, there's not a lot of earth-shattering new programs in this one. It's a pretty granular, detail-oriented tweaks to already complicated methodology. So overall, we've got a number of different tweaks to the hospital payment methodology, but overall, we're looking at a 1.2% increase. Note that hospitals that fail to submit quality data will be subject to a reduction, and that hospitals that are not meaningful users of EHR technology will also get a reduced rate. So we've moved out of the meaningful use stage of the world in which you got extra money, and now you're just punished if you don't do it. So that's great. I'm going to talk through just a few of the specific changes in the rule. This is a 600-page rule that gets extremely granular, so I'm clearly not going to be comprehensively covering its content. Instead, we're going to talk briefly about the 2 midnight rule payment adjustments, a few changes to the hospital quality reporting program and to the hospital readmissions reduction program, and then I'll spend just a few minutes talking at a high level about changes to the methodology for calculating hospital disproportionate share DISH payments. We're going to kick off with the 2 midnight rule here. As some of you know, CMS cut the IPPS rates by 0.2% per year back in 2014 when it adopted the 2 midnight rule. To refresh your memory, the prior rule had been that any hospital stay qualifies for inpatient level reimbursement if it's 24 hours, and the 2 midnight rule
or overnight.
And the 2 midnight rule adjusted this time-based threshold to say that patient stays that are expected to cross 2 midnights, a period of time which is inherently longer than 24 hours, would qualify for inpatient level payment. CMS justified the cut to rates on the counterintuitive theory that this change in the rule would somehow drive up inpatient admissions, despite the fact that fewer people would qualify. Hospitals sued because the agency's reasoning was weak and sort of ill-supported. And the District of DC last year ended up remanding back to the agency without vacating the cut, requiring the agency to explain itself more thoroughly. Last year in the IPPS, CMS, without admitting that it had done sort of a weak job of estimating the budgetary impact of this rule change, reversed the 3 years of cuts by providing a temporary one-time increase of 0.6%. So there were 3 years of cuts at 0.2%, so they were going to make it up by doing 1 year of increase at 0.6%. And as expected in this year's rule, CMS has announced that it will discontinue the 0.6% increase for 2018. There's a small caveat here. CMS has also announced recently, November 9th, that as part of a partial settlement of the still pending, I guess no longer pending litigation, some 67 hospitals that were involved in litigation will have their payments adjusted to account for the inflation interest of the decreased reimbursement during that 3-year period in which the reimbursement rates were cut. Some of the hospitals challenged the rule having it settled. It's probably not the last we've heard. Maybe they'll cut a slightly different deal, hard to say. Obviously, every hospital lost the time value of the amount of the cut during that 3-year period, but only the ones that actually sued about it and settled will be made whole for that.
So there's an interesting lesson in there, right? About if you're sitting on the sidelines in one of these pieces of litigation, there may be a downside to being on the side. There may be an advantage to joining.
Yeah, well, there you have it. There are also some tweaks to the hospital inpatient quality reporting program. This is a program that requires hospitals to report data on certain quality measures in order to receive the full percentage increase in the IPPS that would otherwise apply. The big change here is that the quality reporting measures are moving away from pain management focused questions to communication about pain questions. So in past years, commenters have raised concerns that certain questions about pain management would result in hospitals being incentivized to overprescribe opioids. CMS has generally dismissed the idea that pain management questions would have this effect, but they, in this year's rule, have modified the questions to remove any potential ambiguity. So the old questions were, during this hospital stay, did you need medicine for pain? During this hospital stay, how often was your pain well controlled? During this hospital stay, how often did the hospital staff do everything they could to help you with your pain? I mean, as you can see, those questions are not totally illogically connected to the level of prescription of opioid painkillers. So it's not necessarily far-fetched to think that there might be some connection there. The new questions try to combat that effect and therefore focus on the communication between providers and patients about pain management. So these new questions are, during this hospital stay, did you have any pain? During this hospital stay, how often did hospital staff talk with you about how much pain you had? During this hospital stay, how often did hospital staff talk with you about how to treat your pain? CMS said, in light of the ongoing opioid epidemic, we believe it's important The communication about pain composite measure is abundantly clear, and it's focused on communication about pain between providers and their patients, and it is applicable to all patients who experience pain during their hospital stay. So they think we'll see if this has any effect, but
and we've certainly had discussion internally about how much various quality metrics have had an inadvertent impact on the opioid crisis, because they certainly give physicians an incentive to prescribe. And so I was kind of heartened to see this discussion, because we've been talking about that a little bit internally.
Yeah, there was pages and pages of responses to comments along those lines. I think this is a thing that people have been worried about, and as the opioid epidemic gets sort of increasingly serious, every time you hear about like how many pills are prescribed per capita, it's like sort of alarming. We sort of are more directly confronting this stuff, which is good. Take a little tour through the hospital readmissions reduction program. This program's been part of the landscape for a while. It went into effect back in 2012. General goal here is to reduce hospital readmissions by reducing payments to hospitals that report excess admissions. The trick here is, of course, measuring what is an excess readmission. CMS has set up a complicated formula for calculating excess readmissions based on 3 years of data related to discharges for a few specific conditions: acute MIs, heart failure, pneumonia, hip and knee replacement, COPD, and coronary artery bypass, graft, so CABG procedures. The 21st Century Cures Act, which was passed just last year, requires CMS to adjust hospital scores. So make an adjustment to the calculation of what is an excess readmission, or to reflect that some hospitals have more challenging patient populations and therefore have higher readmissions. The Act directs CMS to assign hospitals into peer groups in order to compare readmission rates in a more meaningful way starting in 2019. This is not a 2018 change, 2019 change. The peer groups will be based on the proportion of dual Medicare, Medicaid eligibles that the hospital serves, on the theory that dual eligibles are especially likely to have difficult cases and therefore experience higher readmissions. CMS determined, after, again, pages of commentary, to split these peer groups into quintiles, so 5 groups, because those are meaningful breaks. CMS brushed off comments that they would need to create tiers of equal size, which I think is sort of interesting, because this assumes that being in the top 20% is meaningful, when maybe there are breakpoints that aren't as even, don't produce groups of even numbers of hospitals that are still sort of meaningful from a policy perspective. CMS was not interested in that argument. So there you have it. And then the last thing I'm going to talk about are some changes to DISH payments. Generally speaking, DISH payments compensate hospitals that serve a disproportionate number of low-income patients. Under the Affordable Care Act, DISH payment calculation methodology was modified, and the mechanics are complicated, but sort of general gist is that the ACA was expected to drive up insurance coverage, which would drive down DISH payments under the previous formula. The ACA created a separate set of DISH payments to cover.
Just for those who don't know what Pari was mentioning, the disproportionate share, that's where the DISH comes from.
Oh, yeah.
And so, but if you don't know what it is, it probably doesn't apply to you. But if that's the DISH is disproportionate share hospital.
Yes. Thanks, David. So CMS created a separate set of these DISH payments to cover uncompensated care, recognizing that the payments would be driven down by the Affordable Care Act. These sort of additional payments are calculated based on 3 factors. The first factor is set at 75% of the difference between the old payment methodology and the new payment methodology. So it's a way of getting at the reduction in payment under the 2 methodologies. The second factor is the change in the percentage of uninsured individuals between 2013, so that's before the Affordable Care Act expansions went into place, and the current year. So that's designed to capture the drive down in uninsurance that the Affordable Care Act was intended to create. And then the final factor is the particular hospital's proportion of uncompensated care. There's a change to the second factor. That's the data source for national uninsurance rates will no longer be the Congressional Budget Office, the CBO. CMS is transitioning to relying on estimates created by its own Office of the Actuary National Health Expenditure Account. For 2018 at least, this new data source reported a slightly smaller reduction in uninsurance than the CBO did, which would tend to drive payments to hospitals marginally up. Hard to say what the impact of that will be going forward. What this slide really focuses on is the change to measuring the third factor, the hospital's own proportion of uncompensated care. So hospital cost reports now include information on compensated care in the newish worksheet S10, which reports charity care and bad debt. For the first few years of this new ACA-related additional dish payment program, CMS didn't want to rely on the S10 data because they thought that it was incomplete and not terribly reliable because hospitals weren't used to having to report it. For the past few years, CMS has used low-income insured patient days as a proxy for uncompensated care. CMS has now determined that the S10 reporting has improved sufficiently that they will phase in relying on the S10 data. This sounds really granular, but this is all a lead up to this one little bit of analysis that I thought was interesting. Promise. So CMS was persuaded to update this approach in part based on comments pointing out that hospitals in non-Medicaid expansion states were sort of disproportionately hurt by the payment methodology in two separate ways. First, remember that one factor driving the amount of the payment is the nationwide reduction in uninsurance. And that reduction doesn't help hospitals in states without a Medicaid expansion as much as it does in hospitals that did have an expansion, because non-expansion state hospitals obviously don't see the same decrease because there's not the Medicaid increase coverage. Second, using these low-income insured days as a proxy for uncompensated care actually tends to exaggerate that effect for hospitals in non-Medicaid expansion states because in these non-expansion states, hospitals didn't see an increase in the number of low-income beneficiaries, didn't see an increase in the number of low-income insured beneficiaries, but did see an increase, at least relative to hospitals in states that had the expansion of uncompensated care. So in other words, the low-income insured days is a pretty poor proxy for uncompensated care, particularly for hospitals in states that don't have the Medicaid expansion. Practically, for all hospitals, this means it matters a lot more if the data on your S10 worksheet is accurate and complete, so it's worth putting some effort into making sure that you're completely reporting your uncompensated care, your charity care, and your bad debt. That's the big stuff from the IPPS this year, which tells you what the unbig stuff looks like. I'm going to toss it back over to David to talk about the OIG Work Plan.
So we're going to work through the work plan at the speed of lightning here, but this is storm chasing will come in handy. So as I mentioned, they changed there used to be a big work plan that came out now. They've decided they don't like that. They're just going to, on their website, work through issue by issue, kind of on a weekly basis. New things will come out. And so I'm just going to whip through some of the most interesting ones, some of them in literally a sentence or two for most cases. So they're looking at bariatric surgery. You know, Medicare only covers bariatric surgery if you've got a body mass of 35 or higher, a comorbidity, and you've had previous unsuccessful medical treatment. And I think they think basically non-quote medically necessary unquote procedures are getting billed. Telehealth, the main thing they're looking at is they're wondering if there are times where they want to reconcile the distant site and the originating site and see if you sometimes have a claim from one without the claim from the other. So they're going to be looking at that. You've noticed a theme for the last several years. The CMS does not like provider-based. They pay more, they hate it, and that comes up. There are probably 6 different specific studies looking at that, and the question they ask is, why do we pay more for the same service based on where the service is provided? And I think we've been talking about this for a while. As I said, we have a great, it was April 2016, Briar Andreessen, Katie Ilton, and Steve Beck did a great webinar on provider-based stuff. If you need to understand any of that, I learned a boatload from that. A topic that first came up to the best of my knowledge when the OIG audited the Cleveland Clinic on a topic that at the time I didn't know about, and I think almost no one else did, which is credits for medical devices where the medical device is recalled and the medical device company provides a credit that is 50% or more of the cost of the credit. And there's a bunch of stuff that goes with that. This is a super hot issue. It's been happening in all kinds of ways. They're looking at the medical device companies, they're looking at hospitals, they're looking at everyone on this. Super hot topic. I don't think people knew about this, until 4 or 5 years ago. I sure didn't, and I don't think I'm alone. There's a lot of stuff in here about skilled nursing facilities, often called SNFs. And you don't get, Medicare will not pay for a skilled nursing facility stay unless you spend 3 days in the hospital. And that has to occur within 30 days of the hospital discharge. So there's look at whether or not there's a qualifying hospital stay. This becomes a big topic, and I'm sure people are very familiar with this, whether someone is admitted as an inpatient or not, and the length of time that takes, because if a stay is 2 days, if you have a day of observation and then a 2-day stay, that can prevent a beneficiary from getting their then potentially long skilled nursing facility stay covered. And so this is a big deal, and admission criteria matter for this, and it's just an important thing to understand. It's why understanding when you can admit a patient to a hospital really matters. So we'll have the next couple of slides are sort of similar. This is a home health thing. Are patients truly homebound and in need of skilled care? The main thing I found interesting about this, look at the asserted error rate. The government claims that 51% of all home health services were unnecessary. And that's mind-boggling, but I think that tells you home health audits are a coming, right? Because they think that they overpaid basically by a factor of 2. They're looking at high-use physical therapy services, so looks for some physical therapy audits to be a coming. This one just caught my eye, accountable care organization, beneficiary assignment. And the beneficiary assignment in an ACO is, I think, bizarre. It is, who do you get the most evaluation and management services from? So you can get into this weirdo land where the patient thinks of their doctor as Dr. A. They only saw Dr. A twice. They saw Dr. B 3 times. Dr. B is their assigned beneficiary, or is their assigned doctor. Really weird. Abuse and neglect is a hot topic. And so they're looking at whether skilled nursing facilities are properly reporting abuse and neglect. In Minnesota, this has been front page news lately. I'm just going to use this as an aside to say, hey, do you need to report all crimes? Just as a general question. Hey, patient walks in with a false insurance card. Do you need to turn them in? So generally, you don't have a duty to report all crimes, but there are a bunch of exceptions. And so one of the exceptions is you need to report abuse. In almost every state, there's going to be a requirement on that. And in the example I was using, if a patient came in with a fraudulent card, generally you can't turn patients in. If a patient comes in and says, I'm using drugs, unless there's a specific exception like that person is pregnant and your state requires reporting there, you can't generally turn patients in for the stuff they tell you about. But if they give you a fake insurance card, I know I'd be worried about whether you have just become a co-conspirator in their crime because you're going to keep the money they get from that insurance card. And so while you don't need to report all crimes, you do need to report both the crimes for which you're required to report and those in which you might be a co-conspirator or a beneficiary. Bundling is a theme that pops up a lot in the work plan. And so they're looking at situations where a patient is admitted to the hospital, but needs a diagnostic test that is not available at that hospital. So hospital A shoots you off to, it could be hospital B, but it really also could be a clinic, right? To get some scan or something. That should bundle. It doesn't always. And they're particularly interested in durable medical equipment, prosthetics, orthotics, and supplies. That's to me post. Because that should also bundle during the stay. They're worried, So the OIG is worried about whether Part D is paying for drugs for people who are on hospice, because when you're in hospice, there's a bundle of care. That anything related to the terminal illness, including prescription drugs, should bundle, and they believe that that is not always happening. Also part of the bundling in the SNF world, ambulance. So a SNF patient needs to go to the hospital and they go in an ambulance. Well, that bundles into the SNF pay, and they're worried about that not sufficiently happening. The 72-hour rule is an old one. I was a baby lawyer when I first was learning about it, like back in the early 90s. And it's the idea that if you get a diagnostic service in the 72 hours before you're admitted to the hospital, that bundles. And this is counterintuitive, because if you break your arm on Monday and then have a MI on Wednesday, that broken arm x-ray bundles into your MI hospital stay. Crazy, but it's the way it works. And the theory is they're afraid that otherwise, if you were coming in, for some kind of surgery, maybe the diagnostic services, people would unbundle them and do them early to get separate payment. So that's the harm that's being avoided. The rule is probably too broad, and they're looking at, once again, whether that is being handled properly. They use a misleading or at least confusing term here, which is they talk about payment for non-physician outpatient services. When I read this title, I thought they meant like non-physician practitioners, NPs, PAs, clinical nurse specialists. That's not what they mean here. They really mean diagnostic services. I think that's just part of the choose your lingo carefully, because it can get confusing. Home health bundles came up, and there's a question as to whether physicians and others are billing for Part B services that a home health agency has already been paid for. So they'll be looking at that kind of bundled stuff. And it's tough. If you bill, it's hard for you to know whether you're treating someone if they're in hospice care or home health care. It is not crazy to try to ask people that, because in theory, you can be on the hook as well as the hospice or home health agency. And so here's the hospice equivalent of that same issue. I believe it was Pari who was talking about healthcare acquired conditions. That prohibition has been out there for a little while. They're continuing to look at it. Duplicate payments for beneficiaries with multiple Medicaid numbers. And we've already, so are you on the hook if the patient comes in with the wrong number? And there are arguments to get you off the hook. The government will often look to you to try to get that money, and we've already talked about the fake insurance card problem. This does not have a direct impact on anyone listening, because we might have a state on, but not many states on. Medicaid is going to be looking to the states because they think states are not doing an adequate job of collecting overpayments. So why am I talking about this if there aren't many states on? Things roll downhill. If they're looking to the states and saying, states, you didn't recover overpayments sufficiently, the state is going to be looking to all of you. And we've seen that. I mean, so I'm now 25 years into my career. In the first 20 years of my career, I maybe worked on one Medicaid audit. And in the last 5 years, I mean, it still isn't hundreds. It's not like Medicare, but it's, a dozen. It's a not insignificant number of Medicaid audits. That number I expect to tick up, which I guess could be tick off. HBO is not just a television station, but the hyperbaric oxygen therapy, and it's often sometimes HBOT. We've got, I think, 3 hyperbaric oxygen things that are either in or we just got rid of one, went to bed. It's always exciting to have one go to bed. But the hyperbaric oxygen therapy has been a source of busyness for us. I've got multiple slides here that list the covered conditions. The topics that we have seen are medical necessity, and then also mobile units, and whether the mobile unit is provider-based or not. I'm not going through all this, but you can kind of look through those slides on your own to see when the therapy is okay. Super hot topic. IRFs, inpatient rehab facilities, have been getting picked on for a long time, often for crazy or inaccurate things. One false belief out there is that you have to provide 3 hours of therapy to someone in order for them to have an IRF stay. That's close to accurate, but what would be actually accurate is the patient has to be able to withstand 3 hours of therapy. What's the difference? The difference is that if someone has 2 hours and 57 minutes of therapy one day, that doesn't convert the stay to non-covered, although certainly some people think that. And when I say some people, I mean both consultants and also some auditors. But they're misreading what it says. That said, IRFs are getting audited a fair amount. We've had a lot of success. By the way, I've got a consultant who has gotten a couple of our clients out of deep doo-doo by making really good arguments in this regard. Ambulatory surgical centers. The government seems to think that they aren't being surveyed adequately, and they note that some were surveyed only every 5 years, and so they're going to look into that. Payments for DMEPOS and whether or not physicians are opted out physicians ordering services. And we're coming up on the top of the hour. I think we'll go about maybe 3 minutes over. Tops, I'm almost done here. So like an opted out physician can order some services, but I don't know that DMEPOS is one of them. They can't order diagnostic tests. And the government seems to be wondering, are prosthetics, orthotics, and supplies being provided to a doctor who is not part of the Medicare program? Sleep disorder clinics, and they're looking in particular at high use of sleep testing procedures. So that's a topic coming. Here's one I toss out. It's also not directly relevant, but it's an interesting one. The government believes that ZPICs, zone program integrity contractors, and the program safeguard contractors are not necessarily recovering cash properly. I mention this because we have had multiple clients get a ZPIC audit telling them you owe X kabillion dollars, and then that X kabillion dollars is never recouped. And I don't know if I should even say this out loud, but one of the lessons here, and you're not supposed to pay when you get the zone program integrity letter. And sometimes, like in one case I'm thinking of, that's because they were collecting money 6 years after the fact, and the Medicare statute doesn't let them recover that money. And I think eventually someone realized it. The client was never told the overpayment was waived, but I'm going to say that happened 5 years ago. I think the overpayment has been waived. The lesson here, don't be overzealous in refunding money because sometimes you just never need to pay. Last two slides, these are not part of the OIG Work Plan. They're part of the Fredrikson and Byron Work Plan. If you are listening to us right now and you are either a physician clinic or a hospital that employs physicians, I want you to at least think about whether you need to provide the advanced imaging notice. If you use the in-office ancillary exception under Stark, and you may want to, you will want to do this notice. And so the people, if you're a rural clinic, you may not need to do this. If you're an urban clinic and you have PET, CT, or MR, you need to do this. And if you're a hospital and you want to pay physicians for stuff that's done incident to their work, you may want to do this. And that means giving a notice to every patient who gets an MRI, a CT scan, or PET. You can do it via email. At the time they get a referral, you have to tell the patient, hey, you can go someplace else, and then you have to list at least 5 suppliers. And remember, technically speaking here, a supplier is a Part B type thing. So an independent diagnostic testing facility or a physician clinic, not a hospital. And if there are any, you have to provide up to 5. If it's fewer than 5, you just list the number there are. They have to be within 25 miles. You can say more than this. If you do not do this, you cannot use the in-office ancillary exception under Stark. And that can have dramatic ramifications if you're a physician clinic. If you're a hospital, you don't necessarily need the in-office ancillary exception. It just gives you some more flexibility. So you can call one of us to talk about this. That's my last slide. So I will wrap up by saying, as kind of I mentioned at one point, you should feel free to call anyone here with a question anytime. We like to help people. So call whoever you want. I got the date of our next webinar wrong because I'm an idiot. It's actually January 10th, not January 17th. And that will be on electronic health records. Breyer Andreessen and Steve Helen will be talking not about the record, but like your contract for an EHR and things you need to know. And there's stuff you need to know. Whoever is responsible for buying EHRs, get them to listen to that. And then Valentine's Day, Katie and I will talk about appeals. Please do your evaluation. We are really interested in topics you want to hear about, so please shoot those to us. And I think we're running, well, there is a question here. We'll just do it real quick. Regarding abuse and neglect reporting, who is ultimately responsible? If a hospital has a policy, is the hospital responsible or is the clinician responsible? The RN, the physician, the social worker? That's a great question. And I think the answer is yes. You know, and it's going to, first of all, it's going to depend, and there are different kinds of responsibility, right? There can be statutory duties to report. Many licensed professionals are going to have a duty to report. In many states, there will be a state law that requires certain professionals to report and may require institutions to report. And then all of that gone, you know, common sense is not dead. If you're aware of abuse and you just sort of roll your eyes at it, the patient's going to have the ability to bring a claim against you. And so I think I would assume, absent someone convincing you otherwise, that you have a duty, right? And then, you know, that's the safe way to go at this, and then let someone show you that you don't. All right, I think that is it. So on behalf of Catherine, Pari, and Marguerite, thanks for listening.